Hey everyone, welcome to Dispense is Written. Today we're going to be reviewing an article that I'm calling 2 Beats 1. Stop doubling your blood pressure medicines, published in Lancet in 2025. Now let's jump right in. So a patient comes into your office. Their blood pressure is still 154 over 100. They've been on a med for over 1 month and they're not at goal. You've got 2 moves. Double the dose of their current med or add a second drug. Most of us probably double the dose. Feels reasonable, feels responsible. Feels like we're giving the first drug a fair shake.
So you're telling me there's a chance?
484 randomized trials say that we are choosing wrong. Let's get into it. All right, so what's the PICO here? The question here is in adults with hypertension who had an average blood pressure in the 150s over 100. How much does each antihypertensive drug and dose combination actually lower blood pressure compared to placebo? The 5 drug classes that you already prescribe every day: ACE inhibitors, ARBs, beta blockers, calcium channel blockers, and thiazide diuretics. Every dose level, every combination, head to head with placebo. The primary outcome is placebo-corrected systolic blood pressure reduction in millimeters of mercury. I know, surrogate outcome. It irks me too. I'll own that. But every millimeter of mercury carries a small percentage drop in major cardiovascular events. This surrogate probably has some teeth. What methodology did they use? Seems like they would need a lot of data. And you're right, they used a systematic review and meta-analysis. The first trial of this kind we'll review on this channel. 484 double-blind, placebo-controlled, randomized trials, only RCTs. No observational data, no cohort studies, just the highest tier of evidence synthesized. They followed Cochrane methodology, which is the gold standard for systematic reviews, and reported according to PRISMA guidelines, another check. Trials were identified through the DREAM database.
In your dreams.
I'll let you decide what to do with that information. All the good things happened in this systematic review and meta-analysis. Multiple investigators reviewed abstracts and trials to see if they fit their criteria, which included adult patients with hypertension and who were followed for up to 26 weeks. Those patients were assigned to one of those 5 main antihypertensive classes. Background therapy, which means blood pressure meds that everyone in the trial was on, not including the intervention or control, were allowed. And the authors did a risk of bias assessment. More on that in a bit. Every result was standardized to a baseline of 154 over 100 blood pressure. So the numbers are directly comparable across all trials. And they used estimated mean differences in blood pressure plus 95% confidence intervals. And now for results. 45% of included trials were published in 1990 through 1999. The 90s were a pretty wild time, if I remember correctly.
I would have loved to have been in my 20s in the 90s.
Good data age as well, I guess. So, who was in these trials? Over 100,000 patients across the 484 trials. The mean age was 54 years. 55% of folks were male, 45 were female. And again, the average blood pressure was 154 over 100. I'd grade this as a pretty well-represented hypertensive population, and there was a good mix of folks that were on background treatment and those that were not. The risk of bias: 80% of trials were rated as low risk of bias. 20% had some concerns, most commonly because of missing outcome data, and less than 1% were rated at high risk of bias. This is pretty clean evidence. Now, what does a single medication actually do? Standard doses, shown here, are what I usually start as initial doses when seeing patients. You can also see that they use half the standard dose and double the standard dose as other categories for comparison. Standard dose monotherapy resulted in an average reduction of 8.7 millimeters of mercury across all the classes. ACE inhibitors by themselves 6.8, ARBs 8.5, beta blockers 8.9, calcium channel blockers 9.5, and thiazide-like diuretics 10.8, the only class that consistently beat the moderate intensity threshold. Maybe chlorthalidone deserves a little more credit than it gets. 79% of standard dose monotherapies are low intensity, less than 10 millimeters of mercury. And doubling the dose, it really only gets you 1.5 millimeter more reduction on average. Beta blockers only get you a half a millimeter. You can't even measure that in an office setting, like at all. If you add a second medication at a standard dose, you get 14.9 millimeter reduction, nearly double. That incremental gain from the second medication is 6 millimeters, from doubling the first drug's dose of 1.5. So adding a second medication is 4 times more effective than dose escalation. Okay, so let's orient to figure 4 because I think it's really important. Across the top, you can see that there are 3 main classes of medications. The ARBs, represented by losartan, the ACE inhibitors by lisinopril, and beta blockers by metoprolol. Down the left column, you'll see that there is 2 other medications, amlodipine at 0, 5, and 10 milligrams, and hydrochlorothiazide at 0, 12.5, and 25 milligrams. So if we take lisinopril, which is a common medicine that most people start for hypertension, at 10 milligrams, on average, you're getting about 7 millimeters of mercury reduction, 7 points. And by doubling the dose, you get a 10-point reduction, so an additional 3 points. But what happens if instead of doubling the dose, you add a second medicine to that 10 milligrams of lisinopril? The first yellow square underneath the 7 shows what happens when you add amlodipine 5 to lisinopril 10. You get a 15-point reduction in blood pressure. That's 5 additional points compared to doubling the dose of lisinopril. And if you kind of like hydrochlorothiazide as a second option better, you can scroll your eyes down a little bit further and see that giving both HCTZ 12.5 and lisinopril 10 at the same time gets you a 13-point reduction compared to a 10-point reduction by doubling the dose, so still better. And you can follow this chart for all various combinations, but in general, some takeaways. Dual combination standard dose of medications results in about an average of 15-point reduction. And 80% of folks that are on dual combo standard dose will hit the moderate or high intensity categories as listed below. Remember, doubling a dose only gets you about 1.5 points more. Adding a second on average gets you 6 points more. Another cool thing, the authors also built a free calculator at the website bpmodel.org. You enter a specific drug, the dose, and the patient's blood pressure, and it returns a predicted systolic blood pressure reduction based on actual trial data. This is a real clinical tool. Let me show you how it works. So for our patient at 154/100, if I enter in lisinopril 10 milligrams and amlodipine 5 milligrams, the calculator predicts a reduction of about 15 points. That's the dual combination getting you into moderate intensity territory. Bookmark this one. Now it's time for the Castelli Coefficient, everyone's favorite part, including mine. Presented by, who else? Me. This week's number is a 9 out of 10. 484 trials and over 100,000 patients with a framework for blood pressure intensity that we've needed for a long time. This data aligns with current guidelines and prior meta-analyses that have pointed towards combination therapy being superior. This paper just gives us a little bit more bite in terms of exactly why and by how much. I know, you're probably thinking, but what about side effects? Greg, 2 medications definitely cost more than 1. I hear you. We know that increasing the dose of the first medication also has a chance of increasing side effect profiles, so it's not an all or none. Plus, many of these medications are also inexpensive and in combination with others, so that should alleviate a lot of cost concerns. One practical note. If a patient needs 2 drugs, consider starting the first, waiting 2 to 4 weeks to reassess tolerability, and then adding the second. This separation gives you a cleaner read on which drug may be causing any side effects, and that information is important for long-term adherence. So why 1 point off? Why a 9 out of 10? You really like this one. I get it, guys, I get it. But ultimately, blood pressure is a surrogate endpoint. It's not patient-oriented outcome. These trials were short in duration, and real-world adherence might change some of these numbers. The framework was right. We're just not sure exactly how close these estimates are. And there you have it. Another trial in the books. If you're interested in the paper, the link is down below. So is a link to that calculator for an estimation that I showed you earlier. If this changed how you think about blood pressure management, share it with a colleague. New evidence every week. This channel is called Dispense as Written. Please subscribe for more, and thanks for joining me.